Dear ladies and gentlemen, I'm Dr. Zhao from Department of Pulmonary and Critical Care Medicine of China-Japan Friendship Hospital. Today, I would present you our research regarding the early rehabilitation of critically illness patients. And I would start today's conversation from this familiar setup. The picture shown above is the patient of mine, Mr. Xu, a 59 years old male, and who was admitted to ICU through emergency department for ARDS. And he was undergoing ventilator support for tracheostomy and continuous micropump sedation. What made us decided to provide Mr. Xu a referral? Being a physician, I hope my patients not only to survive, but to return to work or back to home. The PT doesn't want the patient to be completely immobilized due to the sedation. And RT wants to stop intubation for patients as soon as possible. Nutrition therapists want to know how much extra energy the patient needs to expand if active. And OT wants to know how to work early with PT. And Mr. Xu's case indicates our position to prevention patients from post-intensive care syndrome. We call it PICS, and there is no consensus yet on an official definition of PICS. However, clinicians have agreed with this term describing below as is all new or worsened impairments in the physical and cognitive and mental health. Impairment originating after critical illness and persisting beyond acute care hospitalization. And the peaks can decrease neither the family nor the survivor's quality of life. The peak theory is from clinical practice. Yet, identically, the WHO came up with a similar assumption from a more functional prospect. That means International Classification of Functioning Disability and Health. We call it ICF. The ICF conceptualized functioning as a dynamic interaction between a person's health condition and environment factors and personal factors. Beyond on the ICF theory, 25% of critical care population at 6 months suffered moderate to severe disability associated with immobility to return to previous activities such as work and education, and reduce the health-related quality of life as assessed by the EQ5D. And the era has given us the opportunity to change mindset. The reality is that more and more patients are surviving in ICU. The management of critically ill patients essentially increase their life expectancy. That some people who might not have survived 20 years ago. Our duty is that once a patient is clinically stable or able to leave to the ICU, we need to try our best to ensure that they are able to retain maximal functional capacity. Yes, I think it's our duty. This diagram shows a schematic roadmap depicting personal recovery after critical illness according to disability status. A proposal journey for a patient experiencing an episode of critical illness using the WHO DAS disability measure, with 3 possible recovery trajectories elucidated from screening using the WHO DAS, Disability status is determined from comparison of baseline and post-critical illness screen at 3 months. Here are some photos from the internet. From the pictures showing patients in different places all over the world, we found that the situation of critical ill patient is no longer the same as we imagined. Intensive rehabilitation has changed dramatically, starting activities earlier and earlier. These changes are the result of joint efforts of PTs and MDT experts around the world. And evidence and studies about told us importance of early rehabilitation, but it is necessary. In 2005, the one-year mortality rate for critically ill patients was approximately 30 to 70%. Serious comorbidities with worse quality of life and poorly functional status. In the United States, ICU costs are as high as $9 million per day. So it's a very, very heavy burden. Yeah, I think so. And pathological features include heart failure, ARDS, sepsis, acute renal failure, and pneumonia, and so on. Now I think the concept of prevention replace the passive therapy is now seeing benefits of early activity, but not just the downside of the bad breaking. And the benefits of early rehabilitation in critically ill patients includes can improving lung function by optimizing VQ ratio and increasing vital capacity and airway cleaning technicals, and can reducing adverse effects of bed rest, improving patients' cognition and awareness, improving cardiovascular fitness, and improving mental health. So also can reduce time of mechanical ventilation and reducing time spent in ICU and hospitalization, preventing pressure ulcers. So I think, and so many benefits of early rehabilitation in ICU, and many benefits, I think. And here we show a diagram of ICU liberation bundle, I think, which indicates the essential for ICU liberation. So I think we should call for action for ICU liberation bundle. It includes A, B, C, D, E, F, and the 6 elements. And I will dive into each elements in the following discussion. And is the bundle useful? Yes, I will tell you something below. And by fostering a holistic approach to treating patients and improving ICU team communications in the ICU liberation bundle, and has been by fostering a holistic approach to treating patients and improving ICU team communication, the ICU liberation bundle has been proven in multiple studies involving more than 20,000 patients to decrease the likelihood of hospital deaths within 7 days by 68%, reduce delirium and coma days by 25 to 50%, and reduce physical restraint use by more than 60%. Cut ICU readmissions in half and reduce discharges to nursing and rehabilitation facility by 40%, and assess prevent and management pain, SAT, and SBTs, and choice of analgesia, and sedation stand for airway management. And according to the ICU liberation bundle, it's the first three A, B, C elements um, means stand for airway management, SBTs, and coordination of care and communication among disciplines. A elements consist of assessing, preventing, and managing pain, and B elements consist of both SAT and SBTs, and C elements consist of choice of analgesia and sedation. And this is element D. The components of an effective delirium prevention management strategies include we must have validated to detect delirium and focus on non-pharmacologic approaches and implementation and adherence to pain and sedation protocol. And here is some recommendations to reduce the burden of ICU delirium. And that include that modified ICU environment and push reorient patients and detect delirium. And the first one is evaluate for reversible causes and minimize the impact of medicines. And element E, the protocol of early mobilization. And this slide shows ICU rehabilitation. And this slide is initiation criteria. And this is ICU rehabilitation initiation criteria. And this side is discontinuation criteria. And according to different RASS, we provide different early mobilization suggestion to the patients from level 1 to level 5. And if the discontinuation criteria are not met, step up to the next level. For example, if we do give the patient's suggestion is ROM, and when the PTs do RMF for the patients, they don't match the discontinuation criteria. And the second day, we can go set up to the next level, level 2. Conduct resistance training for areas with an IMRC score less than 3. And in the discontinuation criteria are met if we give the patient level 3, but he met the discontinuation criteria. So we must lower the exercise level, maybe level 2 or maybe level 1. Yeah, and this is a prospective multi-center cohort study. Altogether, 68 ICU collected data during a 20-month period, and 15,000 to 26 adults with at least one ICU day. And the primary focus of the collaborative was to compile knowledge and toolkits for wide-scale dissemination and implementation of ABCDE bundle and to measure the relation of current expand region of the bundle, which includes pain assessment and family engagement with patient outcomes. And we can see if the ICU use elements of the bundle, the percent was much higher, and it can reduce the mechanical ventilation days and reduce coma and delirium days, and can reduce physical restraints, and also can reduce ICU readmission rates and discharge to facility rates. So now we know all the benefits of early mobilization or early rehabilitation in ICU. I think someone can ask this question: is early rehabilitation safe? Yes, 2007. I think some studies can told you that it's early rehabilitation in ICU is safe. 2007, early activity is feasible and safe in respiratory failure patients. 2008, early intensive care unit mobility therapy in the treatment of acute respiratory failure. And 2009 and 2013, safety culture in Australian intensive care units. And so I think although early rehabilitation in the ICU may lead to many increases in heart rate and blood pressure and decrease in oxygen saturation. But the effect is not significant and doesn't need additional intervention. On the contrary, early rehabilitation can lead less time in ICU, reduce delirium, improve functional independence. Good state have when they leave hospital. And best at early rehabilitation and maybe some new technology can use, just as early neuromuscular electrical stimulation, NMES, and a recent meta-analysis has shown that early implementation of NMES in ICU patients also decrease MV duration and ICU and hospital LOS. This is an RCT research. The patients were divided into two groups. EM means early mobilization and EM plus NMES. Both groups received the EM daily. In the EM plus NMES group, patients additionally received the NMES 5 days a week for 60 minutes, starting in the first 48 hours of ICU admission until ICU discharge. And this is the baseline characteristic, and this is the baseline characteristics of the patients who completed the protocols with age, female sex, sex, and other body mass index, and stroke, and so on, sepsis, and others. And we can, so the main results of this study shows that critically ill patients who underwent early NMES and EM compared with EM only, and we can see the higher scores in both functional areas and in the MRC in the first day awake, ICU hospital discharge. And so we can see EM and plus MES have the high first day awake high score and discharge and ICU and hospital discharge. And MRC also have the high score with EM plus and MES. And so the secondary outcome we can, so functional status now. Also strains were also assessed using PFIT score or MRC-SS. In the first day awake and ICU and hospital discharge patients receive and the main results of this study shows that critically ill patients who underwent early EM plus AMES compared with EM only had higher score in both function. This functional yes, these functional scales assess use FS yes FSSICU and PFIT scores and EM plus NMS until and the first day awake, ICU discharge and hospital discharge have the higher score. And they also took fewer days to stand up for the first time and had shorter hospital LLS and lower frequency of ICU AW. Yes, so I think the study shows EM plus and MES have a significant higher score of functional status, and the secondary outcomes they also see just like the diagram. We can show the first day awake at ICU and the hospital discharge and patients receive NMES plus EM have significant improvement in the functional status as muscle strength. And in addition of this objective reason, really, anything else reflecting on? Yes, anything else? There are still some obstacle to early activities, such as physical therapist ability to practice in ICU, lack of human resource and equipment, and priority treatment is not PT, and the patient was sedated. So I'd like to expand here a little bit regarding the PT's ability to practice in ICU. They have no training in addition to clinical skills such as leadership and communication, nor professional certification system. So I think our PT students completed a minimum of 10 to 12 weeks of ICU rotation. No, and PT students, we have not enough the teachers and students. Now, during the COVID-19 pandemic, we think we must discover the new methodology to support early mobilization through modern technology. Robotic assisted therapy could be used to apply passive mobilization. Additionally, the use of advanced data analysis techniques such as artificial intelligence, data mining, or process mining may detect similarities or trends among patients whose early mobilization programs could be slightly adjusted with personalized recommendations using the high-level knowledge acquired. The automatic real-time feedback received from sensors data could significantly shorten recovery times and minimize the PICS side effects. And this diagram shows a smart health oriented. Yes, a smart health oriented scenario. And this picture shows a smart healthcare enhanced early rehabilitation. In this setting, physicians count with a system that consider input data, such as electronic health records and physiological and context parameters acquired in real time, activity data from actigraphy and motion sensors to personalize and activities of the EM protocol. I think it may be useful in the future, and this is want to establish essential cardiopulmonary PT service in acute care settings in China. And the MDT involved in early rehabilitation means medical specialists and treatment specialists such as PT, OT, ST, and RT ACT, and nursing specialists and management experts, other relevant teams, just such as social workers. I think the most basic team member for the MDT is critical care specialist who gives the major decision makers and critical care specialists, the patient coordinators. And PT and RT, I think they should make the best time and set daily ward rounds. And this shows the co-member of the MDT for early rehabilitation teams. And I will show some artwork for early rehabilitation ICU to you. And this is my team. Pre-rehabilitation for him. He's a people organ transplant. Working on and these are teams. Do you still remember the doctor from Wuhan and Dr. Yifan is the cardiologist whose face turned dark during COVID-19 treatment. And we also do early mobilization for him. And to end the lecture, I'd like to use an early video of Dr. Yifan to emphasize the importance of early rehabilitation of ICU. It brings lots of benefits to patients by following the step of ABCDEF bundle.
上个星期我4个人说一下和病毒作战就打，最后这场战役打赢了，也会变白。